try my best to make it clear as much as possible. First, let me introduce my institution, Taichung Veterans General Hospital, Taiwan, located in the central part of Taiwan, Taichung City, and it's founded in 1977. Just passed the 2011 hospital accreditation and also 2011 teaching hospital accreditation of Taiwan, both graded as highest grade, super excellent and excellent. This is the organization chart of my hospital, and it's quite large, consists of more than 1,500 beds totally. And its medical service is also huge, consisting of more than 1.4 million outpatient visits and more than 46,000 of in-hospital hospitalizations. And our hospital is the earliest one to start to participate in QC activities in Taiwan, especially for medical industry. Our QC activity was supervised and organized by our Health Care Quality and Patient Safety Committee, QPS, of our institute. And there will be more than 100 circles each year for the in-hospital contest. And CC circle comes from cardiovascular center. This is the photo of our major star. And the fruit is the result of fruitful for our QCC activities. For example, we started to participate in the national contest for Taiwan, and we won several medals from 2004 to 2006. Also, we started to participate both groups of the contest, and we won gold medal for the 3 consecutive years for Taiwan Joint Commission on Hospital Accreditation, TJCHA. We also won gold medals for several times from the contest held by Association of Pioneer Quality Control Research, ICQCC. With this above good result, and we also won the gold medal for holistic care in the contest of Healthcare Quality Improvement Campaign 2009, also held by TJCHA. And we also present our good results in the ICQCC for the past 4 consecutive years. We joined the Beijing meeting, Dhaka meeting, Cebu meeting, and last year Hyderabad meeting. CC Circle came from the cardiovascular center, and one of the most important department, coronary care unit, CCU, is a special ward and special for the most severely ill patient, cardiac patient. And it's established in 1996, and we have now 39 members and 16 beds. Most of the patients we take care are myocardial infarction, unstable angina, arrhythmia, heart failure, and coronary artery disease. And the admission is more than 1,800 per year. The name CC Circle came directly from cardiac care, and it's specific for our cardiac patient. And you can see, to see, make a circle, that also means make your life and your heart complete. And it also pronounced like C in Chinese. So it means happiness, health, and harmony. I think Mr. Chairman can understand this concept. And the member of CC Circle consists of a multidisciplinary team. It consists of cardiologists, nutritionists, pharmacists, physiologists, therapists, and nurses. And the above members have the average work year is more than 10 years. And our QC meeting or QC education was held once per week. And the theme selection based upon the theme itself and the superior authority and the circle itself. We voted for the different kind of topic and theme, and we select global cardiovascular risk management for patients suffering from acute myocardial infarction. And the enrollment criteria was for all patients who are going to be discharged from our cardiac care unit with a diagnosis of acute myocardial infarction. That means that when you survive a heart attack, we will enroll all of these kind of patients. And this is the QC story chart. According to this chart, we would like to make a breakthrough of current condition, and several new tools will be created, and also we would like to achieve a goal with a brand new program. So we decided as a task achieving QC story. And this is our theme project milestone chart. For Gantt chart, you can see several weeks of delay in the earlier stage because of the delay was due to a prolonged literature searching and summarizing. And later, a small delay because of discussion in the creation or the discussion about tools and explore settings. But we can keep on our pace after all. So I would like to spend more time in the process rather than the regular format, because of this is the most important part of our group. First of all, we would like to make a global risk management. So first we have to know what's the risk. The traditional risk factors for cardiovascular disease consist of 7 parts. It's hypertension, dyslipidemia, diabetes, obesity, smoking, and physical inactivity. What's the real problem for Taiwanese adults? According to the 2008 National Health Survey, for Taiwanese adults, there are more than 80% of Taiwanese adults have one or more risk factors, gout risk factors. So if the problem is not so small, not too small, it's quite a big problem. What's the impacts of the risk factor? For example, if you have a hypertension, also you have a high lipid, high cholesterol level, about 245, your death rate per 10,000 patient years is 34. If you don't have both, the death rate is only 3. So it's a 10 times less, or it's a third, more than 30 less, the death rate. So it's very, very important. According to the largest study called Inter-Heart study, study about the risk factor for the first acute myocardial infarction overall in the world, it consists of more than 40,000 patients. And it found that there are 9 risk factors: smoking, diabetes, hypertension, obesity, psychosocial stress, less intake of vegetable and fruit, less exercise, too much or too little alcohol intake, or lipid abnormality. And about all these factors can account for more than 90% of the reason why you have a heart attack. So these 9 risk factors are very important. Accordingly, if you take a look or manage the hypertension, hyperlipidemia, diabetes, smoking at all, we can prevent or cure cardiovascular disease and prevent you from a second heart attack. So what's our aim? What's our aim? To know our aim, we have to know first the risk factor associated with hypertension, hypercholesterolemia, and so on. Is there a threshold? According to a study published in 1997 called Mr. Fit study, we can see that the higher your, no matter your systolic blood pressure or diastolic blood pressure, the higher your blood pressure, the higher your relative risk for a heart attack. So there is no clear cut or no threshold level when your risk will increase. In the same study, also found that your blood cholesterol level, the higher your blood cholesterol level, the higher your current heart disease mortality. So it's very, very important. There is no clear cut or threshold level. So the lower the better is the answer. So secondly, the impact of modifying risk factor. What how come we can modify the risk factor and what's the result? And you can say that you can save the best for the worst. It means that the impact of modifying these risk factors, the greatest impact is on those at highest risk. For example, if you lower your blood pressure in a patient with high blood pressure and also already have coronary artery disease or end organ damage, the number needed to treat per year is only 9. That means you can treat 9 patients with blood lowering agent and you can save 1 life per year. So the number is very, very small and very cost effective. For example, for the other way, if we treat the hyperlipidemia by lipid lowering agent for the secondary prevention, although the relative level of risk reduction is similar in primary or secondary prevention, but the absolute level is quite big for secondary prevention. So the number needed to treat in this kind of high-risk group is on 8. That means you treat 8 persons for hyperlipidemia for 1 year, you can save 1 life. But actually, and the reality is, for Taiwanese adults, there are 11% of them have hypertension, but only 13% were well treated and controlled according to this pie chart. And there are 23% of Taiwanese adults have hypercholesterolemia, and only 14% is well controlled and treated. And 6% of Taiwanese have diabetes, and unfortunately also only 27% of them were treated. So the challenge for us is not so small, it's quite big for us. Not only for Taiwanese adults, also in the US study, for US managed care patients, if they have both hypertension, hyperlipidemia, less than 10% of them were well treated and controlled. So the problem is, when we have to treat the patient, we have to treat them in a good level, in a normal level. So what's now, before this QC is initiated, we collect data from 32 patients with first acute myocardial infarction and ready to be discharged. And we pick up 10 risk factors according to literature searching. We pick up blood sugar, smoking, body mass index. That means you have obesity or not, good cholesterol, HDL, hypertension, good bad cholesterol, LDL, and the level of blood sugar control, hemoglobin A1C, and uric acid, total cholesterol, and triglyceride. We pick up these 10 risk factors and check data from 32 patients. We found that there were a total 155 risk factors. So the average risk ratio is 48%, 4.4%. And without QC initiative, we regularly measure these 32 patients and check again 3 months later. We found that the average risk ratio is still the same, almost the same, 47.2%. And so we have to act to get where we want to, how to get to where we want to be. First, that's the result of our group. That comes from lifestyle modification and combination therapy and monitoring the behaviors of treatment or therapy. What's the most important thing for lifestyle modification? What kind of lifestyle? Based on the study and the literature, we can find that healthy diet and adequate physical activity, you lose your weight and have a moderate alcohol consumption or quit smoking. You have always good influence on your blood pressure, also your lipid level and your sugar level. So it's very important. How to improve the adherence, office tool and physician examiner, motivational interviewing, and prescribing regimen for higher probability of adherence. So the strategy one is to team up a team-based framework that consists of cardiologists, nurses, nutritionists, pharmacists, physiatrists, and therapists, and nurse practitioners. And strategy 2 is we like to use a new approach. Following is the new approach we developed, First, we broadcast at 3 months of follow-up and did it by our nurse practitioner, and we inform the physician about the results. Secondly, bedside instruction of medication by our pharmacist. And also we created a blog called CC blog, and it makes interactive communication possible. It's a very real-time communication. And we have more medication teleconsultation by our pharmacists twice a month, and dietary nursing teleconsultation by nurse staff twice per month. And we also created an educational DVD program for the patient for this education. And new education material consists of our strategy 3 and this material, cardiac care recipe provided by our nutritionist, and illustrated brochure for heart meditation provided by pharmacists, and also cardiac care DVD produced by our staff with animation and narration. So the result generally, according to this figure, we can find that after QC activity, each component of risk factor have great improvement from 25% to 71%. In general, we can look back again for before the QC, the average risk ratio is remain the same after 3 months, but after QC, the average risk ratio decreased from 47% to 25%, and each component had a significant decrease at all. And the absolute risk number before is 4.8 to 4.7. After QC, the absolute number decreased from 4.7 to 2.5, and it's significantly difference between after and before. And what's the possible long-term result before QC initiated the Framingham risk score? That means your 10-year risk of heart disease or heart attack decreased from 16% to 10%. That means we may have a 6% difference for the 10-year heart disease risk for the patient. And the maintenance phase, we can see here, the risk reduction ratio, our goal is 30%, and it remains good in the following and maintenance phase. And the average risk ratio goal is 30%. We can see it almost remain below 30% of the maintenance phase. So, Mr. Chairman and ladies and gentlemen, in conclusion, implementation of evidence-based medicine and comprehensive global cardiovascular risk management by an interdisciplinary team could effectively improve risk score of patients who survive heart attack. Hopefully, our approaches could be also useful for other patients with similar cardiovascular risk factors. Thank you so much.
発表ありがとうございました。発表ありがとうございました。今のご発表に対して、質問、コメント、おありの方はいらっしゃいませんでしょうか。ございませんか。私、一つ、質問をさせていただきたいと思います。発表ありがとうございました。一番最後にですね、素晴らしい成果が得られていると思いますが、台湾全体に対するインパクトという意味で、今回のご研究の、標準化というか、水平展開というのは、どういうふうに進んでいるのでしょうか。
Thank you for your question, Mr. Chairman, and it's a great idea. And I think we did our result and our practice together, and we standardize them based on the previous result of the QCC activity. And we continue every QC activity, and we continue to implement into our regular work. For this thing, actually we have extended our activity to all patients who will be discharged from our regular work or from our I will both be very happy if I have the chance to present our results for the next year's ICQCC result. Thank you very much.
ありがとう。さらに一歩進めて、台湾のさらに一歩進めて、台湾のいわゆる厚生省レベルまで水平展開していただければ素晴らしいんじゃないかと思います。他にご質問ございますでしょうか。の OK？ そしたら、ありがとうございました。